Professor Lambiase from London, talking about the inflammatory VT substrate.
All right. Thank you very much. So I thought I'd start with a clinical case. This is a 49-year-old IT consultant who actually presented to casualty with dizziness. He had hypertension, was treated with amlodipine, and he actually presented to his GP. Originally, GP noticed he was quite bradycardic, 30 to 40 beats per minute, and he was in complete heart block with a junctional escape rhythm of 40. So his initial blood test, he had a creatinine that was slightly elevated, 123. I'll show you the chest X-ray in a moment, but he had a normal echocardiogram, and there was a suggestion the right hilum might look a bit bulky, but on formal reporting by the radiologist, it was reported as normal. He had a dual-chamber pacemaker implanted for complete heart block and was sent home. And then 18 months later, he represented to A&E with a short history of dizziness and breathlessness. And as he was being triaged by the nurse there in casualty, he fainted. And he was in VT with a right ventricular outflow tract VT, which was promptly cardioverted. So the next investigations, his creatinine had become slightly more elevated. Now his ejection fraction had declined to 40 to 45%. He had a normal coronary angiogram. And in order to establish the etiology of this decline in ejection fraction, further VT, we undertook a PET-CT scan. It was transferred to us from his original presentation. And PET-CT is a technique where we're actually looking at radioactive glucose uptake into the myocardium, and there's increased metabolic activity here in the septum and posterior wall of the left ventricle. There was also increased uptake in the hilum and also in the liver. So indeed, there's obviously an acute inflammatory process which was going on to trigger off this ventricular tachycardia. The easiest site to biopsy was the liver, and he had non-caseating granuloma in the liver, and this patient had sarcoid. So here we have a case of a patient presenting with sarcoidosis, originally with complete heart block, but actually went on to develop VT, and the diagnosis was missed. He actually did very well. He had a CRTD implant, and he was treated with steroids and methotrexate, and subsequently his LV function recovered very well 2 years later with no further episodes of VT. So if you're, as an electrophysiologist or as a general cardiologist, essentially myocarditis can present you in a number of ways. It can present you with syncope, with an aborted sudden cardiac death, non-specific ECG abnormalities such as conduction disturbances and ST changes, as well as supraventricular tachycardia, complete heart block, and VT-VF. So the initial insult is that either a virus or a primary autoimmune insult, leading essentially to myocardial injury, subsequent inflammation, a degree of edema, which may essentially be arrhythmogenic in the acute phase, and then leading on to scar formation, which will then equally be arrhythmogenic and lead to impairment in LV function. And indeed, you can get an ongoing chronic inflammatory process occurring within the myocardium with a waxing and waning presentation of gradual deterioration in LV function and runs of arrhythmia, whether they're atrial or ventricular. And this is important to us because we see a lot of patients with cardiomyopathy, and certainly in my practice I get referred a lot of patients who have ventricular arrhythmias or ventricular ectopy with a cardiomyopathy. And this study from UCL really highlights the problem of the fact that we have a large proportion of patients that remain undiagnosed with a myocarditis. This is a study of a group of patients who actually had ventricular arrhythmias, be they those VEs, non-sustained VEs, VT, or sustained VT, ejection fraction less than 55%, and they actually had an abnormal cardiac PET in 50% of cases. This is some examples of those PET scans. So essentially here, simply hot uptake and within the myocardium with normal perfusion, and here uptake within the lymph nodes in a patient with sarcoidosis, similar to the patient I presented. And of course, with ongoing inflammation, there can be scarring with these perfusion defects within the myocardium, which act as a substrate to support re-entrant VTs. This is an example of a patient who previously had a viral myocarditis with ongoing inflammation within the myocardium and a classic anterior scar with late potentials because they had an ongoing chronic condition. This is another example of such a case, a 40-year-old Cypriot lady who actually presented to me with polymorphic VT on amitriptyline. And we stopped the amitriptyline, did an MRI scan, and you can see here on MRI she has a fixed defect in the posterior lateral wall. Being Cypriot, we did genetic testing for ARVC, which was negative. But she also had a lot of LVOT ectopy, which I ablated, and she had well-preserved LV function, but we kept an eye on her with Holter monitoring. And on a Holter here, despite having stopped antiarrhythmic medications and amitriptyline, she still had a run of very nasty-looking polymorphic VT. And given the fact she had a fixed scar, we had a suspicion that she had a low-grade myocarditis. But with this polymorphic VT, we implanted an ICD. And a year later, she developed VF in her sleep and was promptly cardioverted. So it's really just to highlight to you that these patients can have a waxing and waning course and still go on to develop malignant ventricular arrhythmia. So how do we diagnose these inflammatory diseases? Well, essentially, a biopsy is the gold standard. You can have a range of changes from a lymphocytic myocarditis to acute sarcoid to more aggressive forms such as giant cell myocarditis, where patients may actually present with cardiogenic shock. The problem is biopsy is not very accurate. So if you take a single biopsy in the right ventricle, and this is a study done in Germany where they took an explanted heart and did multiple biopsies in a patient who'd had a transplant, died as a result of a fulminant myocarditis. On one biopsy, 18% diagnostic accuracy, 5 will give you 43% positive test, 17 biopsies gives you 82. Most of us will do 1 or 2 gingerly within the right ventricle. So the diagnostic yield is quite low. Fortunately, we have imaging, so one can use MRI. T2 mapping will give you evidence of edema within the myocardium in the acute phase. This is early gadolinium enhancement may give you an indication of hyperemia or thrombosis within the microvessels within the myocardium during the acute phase, and then subsequently with fixed scar formation, late GAD will give you an indication of localized fibrosis. And these patients can have a waxing and waning course. They may simply recover spontaneously on their own. They may go on to develop heart failure symptoms or develop ventricular arrhythmia. And this just shows you the sort of parallel ECG pattern. Here we have a patient with acute lymphocytic myocarditis who initially presents with VT, and then having been treated with steroids, you can see there's marked conduction disturbance within the ventricle here, and then they go on to develop what looks like the sort of pattern you would see in ARVC with an incomplete right bundle pattern, an epsilon wave here, and T wave inversion. This patient did very well. They were treated with steroids and recovered their LV function, had no further ventricular arrhythmia. And this really brings me to the next part of the talk, which is to talk about arrhythmogenic right ventricular cardiomyopathy. Because ARVC we take to be an inherited condition due to mutations in the desmosomal genes, the linker proteins between the myocytes. But actually, there can be an important component of these patients who actually have an ongoing myocarditis. This is a series of 30 patients who were mapped and biopsied in the low voltage areas. And in these 30 patients who had typical features of ARVC, they actually had evidence of a lymphocytic myocarditis in 50% of these cases. Indeed, when these patients were treated with steroids, they had a very low burden of ongoing arrhythmia compared to those who definitely had ARVC without inflammation. This is the events from device implantation. They had a significant burden of ongoing ventricular arrhythmia. So this is to make the point that myocarditis can actually present with an ARVC-like pattern, with T-wave inversion on the ECG and an incomplete right bundle pattern. Indeed, in this case, this is a patient who presented with VT and actually had troponin rise in a typical ARVC type ECG. They had wall motion abnormalities on echo, and eventually, after a year, had evidence of gadolinium late uptake within the left ventricle. And this is a series of patients who actually had major criteria for ARVC diagnosed, but they all had PET scans. There are 14 patients here, and 5 of them had positive PET scans. 2 of these went on to be diagnosed as sarcoid, and 3 of them were ARVC gene carriers, definite mutation carriers. This is one example, a desmoglin 2 mutation carrier, desmosomal protein associated with ARVC, and you can see here there's increased uptake within the myocardium, typical ECG pattern. So this suggests that as part of the natural history of ARVC, a proportion may actually have a myocarditis mimicking ARVC, or indeed the fact they have these mutations on the surface of the cell can result in myocyte slippage, maybe myocyte injury, causing an inflammatory response. And indeed, if you take cells in culture and introduce a number of cytokines, IL-17, TNF-alpha, and IL-6, it'll downregulate plakoglobin and actually give a picture on histology that looks like ARVC. So essentially, these observations suggest that myocarditis can mimic ARVC, both clinically and on a cellular level, and that myocarditis might be part of the pathophysiology of ARVC to account for these hot phases of patients developing arrhythmias, which has an important implications for both how we image these patients and potentially disease-modifying drugs. The other point I want to make is if you see a VT, a negatively concordant VT in the absence of coronary artery disease, it's very likely that you're dealing with a patient with sarcoidosis. Sarcoid typically affects the apical, inferior apical area of the right ventricle, and left ventricle of patients, compared to ARVC, which tends to affect inflow tract, outflow tract, and apex. If you're going to suspect ARVC in your patient, first of all, there are a proportion of patients who have if you're going to suspect sarcoid, you're going to have a proportion of patients who have histological sarcoid at another site, for example, in the pulmonary vasculature or on the lymph nodes. But essentially, if they have evidence of wall motion abnormalities on echo, conduction disease on ECG, late gadolinium enhancement MRI, then have a high index of suspicion. They also have cardiac sarcoid, which has important implications for their management. The VTs in sarcoid have two mechanisms. One is local reentrant VT in over 85% of cases, and the other group, 15%, will have Purkinje-related automatic activity associated with VT in the sarcoid patient. So, is there much evidence to support management? Well, management is mainly empiric. There are very few randomized controlled trials, how we treat patients with myocarditis or sarcoid for ventricular arrhythmia. The initial management for VT and sarcoid is really to use immunosuppression and antiarrhythmic drugs, steroids and steroid-sparing agents such as methotrexate, and also to predominantly use amiodarone to suppress the arrhythmia. It's not appropriate to undertake ablation in the first instance because you're dealing with a very inflamed substrate. Ablation really has a role later on when there's more fixed substrate within the myocardium if they're developing ongoing VT. This is quite a complex algorithm, but essentially it's saying if you have a patient with cardiac sarcoid presenting with VT, do an FDG PET. If the PET is positive, then you're going to use disease-modifying drugs and amiodarone as the main antiarrhythmic agent. If it's negative, then you're going to manage the patient with a combination of antiarrhythmics and an ICD. If they have a clinical response, great. If they don't, then obviously the appropriate thing will be to undertake an ablation to try and target the substrate for reentrant arrhythmia or Purkinje-triggered activity. We looked at the literature on sarcoid VT. As you can imagine, it's pretty sporadic. Essentially, we found 5 articles in which you can make gleaning meaningful information from. The mean age of these patients with sarcoid VT was 50. They, on average, had 3 ventricular tachycardias. Mean cycle length 360 milliseconds. You can see here with VT ablation, the mortality was 0. The relapse rate is quite high, 54%. And about a third of patients require redo procedures. But overall, the ventricular arrhythmia burden falls from 88% down to 45% with ablation. So it's a palliative procedure for patients with fixed substrate and sarcoid VT, and 18% of them require epicardial ablation. What do the guidelines say? Well, the ESC guidelines are quite brief, but essentially an ICD should be deferred until you've got resolution of the acute inflammatory episode, because otherwise patients just get recurrent ongoing shocks until you've actually controlled the inflammation within the myocardium. And managing atrial arrhythmias, essentially use a CHAS-VAS score for AF risk if they're in AF for anticoagulation, beta blockers and amiodarone, limited role of ablation because again you're dealing with an inflamed substrate, ventricular arrhythmias, disease-modifying drugs with amiodarone. In this phase where you may be managing the patient with antiarrhythmic agents and prednisolone, one could consider discharging the patient with a wearable ICD jacket. One's going to be loath to implant a transvenous ICD initially because of the risk of infection transvenously, but often these patients will have conduction disease, so you're going to end up needing to pace these patients eventually. One could consider a subcutaneous ICD because it's non-invasive and it's transvenous, but that's really a sort of discussion between a wearable jack and a sub-Q ICD if you're treating them with steroids with immunosuppressant agents. The guidelines for management of sarcoid in terms of ICD are pretty straightforward. If you've got a low ejection fraction and you present with hemodynamically compromising VT, an ICD is recommended. The grey zone is really these patients that have borderline ejection fraction of about 50% and reduced right ventricular ejection fraction. A CMR can be helpful there. If you've got a high burden of scar, then an EP study can be considered for risk stratification. That's based really as 2B evidence on about 50 or 60 cases published in 2 studies in the literature. So in conclusion, for sarcoid, the management of conduction disease should really follow standard guidelines, considering an ICD according to the LV function and the extent of fibrosis within the myocardium. Ventricular arrhythmia management should really focus on disease-modifying drugs, and ablation is really palliative if you've got established scar within the myocardium and ongoing VT. With myocarditis, really the point is that inflammatory cardiomyopathies are more common than we think. Up to 30% of cases of DCM with VEs or VT or apparent ARVC may actually have an ongoing myocarditic process, which could be responsive to disease-modifying drugs. And they're going to, and really it's a matter of serially looking at your patients for progressive ECG changes, having a low threshold to undertake additional imaging for inflammation, looking for transient elevations in troponin. And CT, PET and biopsy, I think, really are emerging to have a role here in trying to diagnose the underlying pathology in these patients and treat them accordingly. Thank you for your attention.
Thank you.
Just going to make a quick advertisement, if you don't mind. We're having a symposium, an EP symposium at Barts on the 17th of June, looking at arrhythmia mapping and mechanisms of arrhythmia. All are welcome. It's on the Eventbrite website.